So in the next few minutes, I will talk on osteoarthritis. See, osteoarthritis is a non-inflammatory, a degenerative condition of the joints, characterized by degeneration of the articular cartilage and formation of the new bone, that is the osteophytes. This is a very, very common disease in our society. Not only in India, all over the world, the degenerative joint disease, osteoarthritis, is very, very common. The joints differ from the country to the country. In India, the most common joint involved is the knee joints, and there will be the hip joints involvement, shoulder joints, cervical spine, lumbar spine, hands, especially the distal interphalangeal joints, proximal interphalangeal joints, wrists, etc. So this is a very common in the weight-bearing joints, such as the knee and the hip. Also in the spine, the cervical spine and the lumbar spine, and the hands, proximal interphalangeal joints and the distal interphalangeal joints. Both the males and the females are affected, more so in the females, to the tune of about 6:1. Women above the 50 years, particularly in the postmenopausal age group, are more prone to get the osteoarthritis. What are the risk factors for this osteoarthritis? Obesity is a very, very common risk factor, and India is the obesity capital of the world. So a lot of the people are obese. So obesity is the one of the important predisposing factor for the osteoarthritis. So premature osteoarthritis is very common in obese individuals. And abnormal mechanical loading, maybe the micro trauma or the macro trauma in the joints. So meniscectomy or instability, sports injuries, trauma. So they're also more prone for the osteoarthritis. Inherited type 2 collagen defects in the premature polyarticular osteoarthritis. Inheritance may be the genetical factors. So they may run in the, some factors are there, polygenic. Occupational, especially the farmers, housewives, squatting for the longer period. So these are also more prone to get the osteoarthritis. And some infections, so septic arthritis, post-septic arthritis, maybe non-gonococcal septic arthritis or staphylococcus arthritis or streptococcal, etc. Some are hereditary and poor posture. So they are all predisposing factors to get the osteoarthritis. Aging process in the joint cartilage. So age is a most important non-modifiable factor for the osteoarthritis. It's a very common above the 60 years of the age group. But even the obese individuals and in the agricultural laborers and the people with a poor posture and prolonged squatting positions, so they get the osteoarthritis even at the age of 40 plus or the 50 plus also. A defective lubricating mechanisms. So you know the synovial fluid, synovial membrane thickening, and lack of the synovial fluid. So there will be the lubricating defects, and there will be the cartilage damage and synovial membrane thickening, some inflammations. So these are all will lead to the osteoarthritis. So incompletely treated congenital dislocation of the hip also, there could be a factor for the osteoarthritis. So this can be divided into the primary osteoarthritis and secondary osteoarthritis. Primary more common than the secondary osteoarthritis. Exact cause is not known. Common in elders where there is no previous pathology. Mainly due to the wear and tear changes. So once it's called as wear and tear disease, but no more a wear and tear nowadays, because we know the understanding of the pathophysiology of the osteoarthritis. So there are some defects in the cartilage, there are some defects in the synovial membrane, there are some defects in the subchondral bone formation, and there are the defects in the new bone formations, there are the defects in the muscle, ligaments, tendons, bursa. So they are all involved in the causation of the osteoarthritis. So no more a wear and tear disease. So these are the secondary OA, secondary to the definite causes, like as I told you, the injury to the joint, maybe the sports injuries, etc. Previous infections, they are very common. Rheumatoid arthritis, deformity, obesity, hyperthyroidism, hyperparathyroidism. So these are all important secondary causes. And there are different types of the osteoarthritis. The nodal generalized osteoarthritis, a crystal associated osteoarthritis, the CPPD or pseudo gout, more common in the women. The common joint involved is the knee joint, and osteoarthritis of the premature onset. The nodal generalized osteoarthritis, you have the abundance nodes in the distal interphalangeal joints, Bouchard's nodes in the proximal interphalangeal joints, carpometacarpal joint of the thumb, that is also involved, and also in the great toe is also very much involved in the osteoarthritis. Hallux, valgus rigidus, knees, hips, epiphyseal joints. So they are all the nodal generalized osteoarthritis. Crystal, that is the calcium pyrophosphate dihydrate, mainly in the women, affects the knee joints. Premature onset osteoarthritis, the previous injuries, a meniscectomy or hemochromatosis. So these are the important risk factors for the osteoarthritis in our area. One is the elderly, age, increase in the age, female, heavy physical labor, obesity, chondrocalcinosis, and previous traumas, either micro trauma or the macro trauma to the joints. They will prone for the early osteoarthritis. So in the primary osteoarthritis, you have the erosive osteoarthritis like your rheumatoid arthritis, spinal osteoarthritis, isolated knee osteoarthritis, and secondary osteoarthritis. The common joint involvements here, often joints involved are the knee joint, number one, then the hip joint, first metatarsophalangeal joint, cervical spine, lumbar spine, distal interphalangeal joints, first carpometacarpal joint, and proximal interphalangeal joints. Some joints are sparely involved in osteoarthritis like ankles, elbows, wrists, and metacarpophalangeal joints. So this is the pathophysiology in the osteoarthritis. There will be the micro and the macro trauma. That is maybe because of the increasing age, obesity, female gender, genetically susceptible individuals, or the previous joint damage. They will lead to the micro and macro trauma to the joints. This micro and macro trauma, they can form the subchondral and articular cartilage remodeling, or they may involve in the altered synovium, or they may cause the biochemical changes and alter the gene expression. So these will lead to microscopic structural changes in the bones and the cartilages, and there will be the signs and symptoms of the osteoarthritis, altered functions, and the exaggerated load, and finally there will be the structural changes visible on your imaging like your X-rays or ultrasound or MRI. Pathology, it's a degenerative condition, a non-inflammatory, but primarily affecting the articular cartilage. Here the cartilage is the most damaged in osteoarthritis. Along with the cartilage, there will be some changes in the bone, synovial membrane, capsule, ligament, and also the muscle. Cartilage is the first structure to be affected in osteoarthritis. There will be the erosions occur. These erosions often central and frequently in the weight-bearing areas. Fibrillation causes the softening, splitting, and fragmentation of the cartilage, occur in both the weight-bearing and the not weight-bearing joints. So there will be the erosion of the cartilage and there will be the fibrillation in the cartilage, making the cartilage soft, split, and fragmentations. So these collagen fibers, they split, and there will be the disorganization of the proteoglycan collagen relationship, and there will be a further softening and the flaking. These cartilage flakes break off and may be impacted in the joint surfaces, causing locking and the inflammation. So there will be the locking in the joints, and there will be the inflammation in the joints. These are all because of the collagen fibers split because of this articular cartilage damage. So the cartilage will be damaged in the form of the erosions, maybe the fibrillations, or in the splitting of the collagen fibers. See the beautiful picture showing you a early osteoarthritis and a severe osteoarthritis. On the right side, you have the early osteoarthritis with the area of the cartilage loss in the center. A small area of the cartilage loss in the center. That is the early osteoarthritis. In the left picture, the more advanced changes with extensive cartilage loss and exposure to the underlying bone. So you are not able to identify the cartilage and the bone here. Almost nullified here. Almost the cartilage damage is much more in the second picture. So there is a severe osteoarthritis where nothing can be done except the arthroplasty. This is the arthroscopic appearance of the osteoarthritis of the knee joint, a fibrillated surface, cartilage and the medial femoral condyle. Aberration of the bone, a bone surface becomes hard and polished as there is loss of the protection from the cartilage. So there is a loss of the cartilage, so the bone is exposed and it is very hard. The cystic cavities form in the subchondral bone because the aberrated bone is brittle and microfractures occur. Then there will be the venous congestion in the subchondral bone. So in the bone, there will be the bone surface will be hard and cystic cavities in the subchondral bone, and there will be the bone is the very brittle and microfractures and some venous congestion. See, this is how it appears. See the superior view of a femoral head from a patient with the radiographic stage 1 osteoarthritis. Just stage 1. We have the 4 stages. In the stage 1, this shows an area of complete cartilage loss with the polishing or aberration of the underlying bone. Now the osteophytes, the new bone formation, they form at the margin of the articular surface, which may get projected into the joint or into the capsule and the ligament, bone of the weight-bearing joints. So it's mostly from the margins of the articular surface. You will appreciate the osteophytes in the cervical spine, osteophytes from the knee joints, osteophytes in the hip joints also. There is alteration in the shape of the femoral head, which becomes flat and mushroom shaped. So tibial condyles become the flat end. See here the osteophyte. So at the margin of the articular surface. Then we discussed about the cartilage and also the bone, the new bone formation, bone becomes hard, brittle, etc. In the cartilage loss, there is the fibrillation, fibers, etc. Now the synovial membrane. So this membrane undergoes hypertrophy and becomes edematous, which can lead to cold effusions. Reduction of the synovial fluid secretion results in the loss of the nutrition and the lubricating action of the articular cartilage. So because of the loss of the nutrition and the lubricating action of the articular cartilage, so they get pain. They are the painful movements will be there because of the synovial membrane thickening and the loss of the lubricating actions. Then the capsule, it undergoes the fibrous degeneration and there are the low-grade chronic inflammatory changes in the capsule. Then the ligament and the muscles. Ligament undergoes the fibrous degeneration. A low-grade chronic inflammatory changes occurs in the ligament, and according to the aspect, joint becomes contracted or elongated. The muscles undergoes atrophy. The patient is not able to use the joint because of the pain, which further limits the movements and the functions. So the ligaments and the muscles, the capsule, synovial membrane, cartilage, bone. So these are all involved in the osteoarthritis. Don't think that it's only the cartilage alone. So along with the cartilage, there are some changes in the bone, some changes in the membrane, synovial membrane, capsule, ligament, and muscle also. See the picture here. So the normal joint, the first one. So you can appreciate the bone. And then the tip, there is a big cartilage and synovial fluid, synovial membrane. So entire capsule of that particular joint, and you'll have the muscle, tendon, and the bursa between the bone and the muscle. So this is the normal structure of the joint. See what happens in the center one, that is osteoarthritis. See what about the cartilage? There is the loss of the cartilage. Both the bones are nearer to each other. So the bone length is very much reduced. And then see the synovial membrane, it is very much thickened. And about the synovial fluid, less amount of synovial fluid here. And the capsule derangement is there. And then see the muscle ligament also. So these are all the changes that occur in the osteoarthritis. Sometimes the new bone formation also will be there. That is, the osteophytes formation also will be there. And in the rheumatoid arthritis, it is a synovitis. So synovial membrane inflammation and more effusion of the synovial fluid will be seen in the rheumatoid arthritis. So you can appreciate the normal joint at osteoarthritis here. So some changes in the cartilage, some changes in the bone, some changes in the synovial membrane, capsule, ligament, and the muscle. So same thing here, the severe osteoarthritis. You can appreciate here, see the cartilage here, see the bone spurs, synovial membrane, tendons, subchondral bone, bony loss, synovial fluid is very less amount, cartilage fragments in the fluid, that is the cause for your locking, then the worn away cartilage, almost cartilage damage is there, and a narrowing of the joint space. So this is a very severe osteoarthritis picture. Here you can appreciate a normal versus an osteoarthritic synovial joint. So on the left half, it is the normal, and the right half, it is an osteoarthritis. See on the left side, you will have a regular normal subchondral bone structure. Whereas on the right side, you can see the irregular thickening and the remodeling of the subchondral bone with the sclerosis and the cysts. So this bone is a painful one. Then the normal thick and the smooth articular cartilage is the normal one. But here there will be the fibrillation, there will be the loss of the value, there will be the degradation of the articular cartilage. Thickening, distortion, and fibrosis of the capsule will be seen in osteoarthritis. There will be the modest, patchy, and chronic synovitis, and osteophytosis, and soft tissue growth of at the joint margin. So these are all the picture. These are the pathological changes that occur in osteoarthritis of the joints. What are the general clinical features of the osteoarthritis? Symptoms, you all know the joint pain, joint instability, there will be the buckling, catching or locking, loss of the function, and morning stiffness less than the 30 minutes because it is a non-inflammatory disease. So if it is an inflammatory of the rheumatoid arthritis nature, you will have a morning stiffness of more than 30 minutes or sometimes 60 minutes, even the 2 hours also. The signs: joint line tenderness, pain with motion, crepitus and joint movements, limitation of the range of the motion, and the bony enlargement at the affected joints. So these are the few symptoms and the signs of the osteoarthritis. Not only the pain, the stiffness will be there, muscle spasm will be there, and restricted movement, deformity, muscle weakness or wasting because of the disuse atrophy, joint enlargement and the instability because of osteophytes formation, and the crepitus will be noticed, and the joint effusion in some cases. Pain and tenderness, usually slow onset of discomfort with a gradual and intermittent increase, not an acute onset. It is a chronic onset, a slow onset of the discomfort. Pain is more in the weight bearing due to the stress on the synovial membrane, and later on due to the bony surface which are rich in the nerve endings coming in contact. So the initial days, the pain is because of the stress on the synovial membrane, and later on it is due to the bone surface which are rich in the nerve endings coming in contact. Initially relieved by the rest, but later on the disturbing the sleep also. Diffuse and sharp and stabbing local pain will be seen in that particular part of the osteoarthritis. The different types of the pains will be there. There will be the mechanical, increased with the use of the pain. There will be the inflammatory phases, and the rest pain later in about 50% of the cases. So in the early times, it is the pain on the activity, but later when the severe osteoarthritis, even they get the rest pains also. These are the possible anatomical sites of the pain generation in osteoarthritis. The pain could be because of the muscle pain, the disuse atrophy, a raised pressure in the subchondral bone that causes the pain. Synovitis could be a cause for this pain. Stretching of the capsule, ligament insertion strain, tendon insertions, and elevation of the periosteum. So these are all the reasons for the pain in osteoarthritis. Almost all structures will cause the pain here. Your cartilage, your bone, your ligament, your tendon, capsule, synovial membrane, all will be a part of the pain process in osteoarthritis. These are the movement abnormalities. Jelly, the stiffness after the periods of the inactivity passes over within the minutes, approximately 15 minutes of using the joint again. Coarse crepitus, palpator here due to the flagged cartilage and abutinated bone ends. So this is very often see with the crepitus, you can feel the crepitus on palpation, or you can sometimes hear the crepitus also in advanced osteoarthritis. Rotation of the movements, there will be the reduced capsular thickening and bony changes in the joints, muscle spasms, or soft tissue contractures. Deformities are very common in severe osteoarthritis. So soft tissue swelling, there will be mild synovitis, small effusions, osteophytes formation, joint laxity, asymmetrical joint destruction leading to the angulation, your varus, valgus, etc. Here the distal interphalangeal joints osteoarthritis. So this patient has the typical clinical findings of advanced osteoarthritis of distal interphalangeal joints, including the large firm swellings. You can appreciate that swellings in the distal interphalangeal joints, abundant nodes. Some are tender, red, due to the associated inflammation of the periarticular tissues as well as the joint. This is the knee joint effusion. A typical OA of the knee joints. In the normal standing posture, there is a mild varus angulation of the knee joints due to the symmetrical OA of the medial tibiofemoral compartments. You can appreciate the inflammation there on both the knee joints here. See, this is an X-ray, shows you the narrowing of the joint space, osteoarthritis. There is pseudo-laxity due to the cartilage loss. Joint is not loaded in the first photograph. See here the instability of the distal interphalangeal joints, instability of the fingers. So unstable distal interphalangeal joints. Able to push the joint from side to side due to the gross instability, a common finding in the late interphalangeal joint osteoarthritis. This is the hip joint osteoarthritis. Osteoarthritis can maximally affect the superior pole, the inferior pole, the posterior part, or other segments of the hip joint. Superior pole involvement with a tendency for the head of the femur to subluxe soprolaterally is the commonest platform. Involvement of the whole joint, concentric OA, is relatively uncommon. So in the osteoarthritis of the hip joint, it is mostly the superior pole involvement is much more common, and there will be a subluxation of the head of the femur soprolaterally is common in osteoarthritis of the hip joints. Here the 4 common clinical patterns of the osteoarthritis. So left upper, young man with osteoarthritis, the one hip joint. So which hip joint is involved here? Right hip joint. Okay. Young man with osteoarthritis of the right hip joint. Left lower, middle-aged lady with osteoarthritis of the hands and the knee joints. So both the knees are involved and also hands are involved. So this is a middle-aged female with osteoarthritis of the hands and the knees. Right upper, middle-aged man with a post-traumatic OA of a single lower limb joint. Single joint, the left knee joint. It is because of the post-traumatic osteoarthritis. And right lower, elderly lady with a widespread destructive osteoarthritis. Sometimes we see such cases. See the involvement of the osteoarthritis here. Both the shoulder joints, both the hand joints, both the hips, both the knees, both the ankles, and also both the foot joints. Here, she must be also having a cervical spine and a lumbar spine osteoarthritis also. So this is a very widespread and also destructive osteoarthritis often seen in elderly women. What are the investigations you require in osteoarthritis? See, it's a degenerative disease and a non-inflammatory disease. Here you don't require any antibodies, but definitely a few investigations are very needed to rule out the secondary osteoarthritis. So most of the blood tests are the normal, your CBP, your urine, urea, creatinine, SGPT, SGOT, thyroid profiles, lipid profile. If the patient is a diabetic, again blood sugars, HbA1c, etc. And X-rays are very, very important to diagnose the osteoarthritis, staging of the osteoarthritis. So here you can see, you can assess the cartilage loss, the subchondral sclerosis, in any cysts are formed there, and new bone formation like osteophytes. The radiographic classification, the stage 1, a bony spurs only. In stage 2, there is a narrowing of the joint space, but this narrowing less than half of the normal joint space. In stage 3, much more narrowed, more than half of the joint space narrowing, that is the stage 3. Less than half of the normal joint space narrowing is the stage 2. In stage 4, there is the obliteration of the joint space. And in stage 5, the subluxation or secondary lateral arthrosis. So this is the radiological classification of the osteoarthritis. And laboratory tests, most of the tests are normal here. But underlying the joint damage, you need the few investigations. Like ESR and CRP, rise in the inflammatory diseases. If there is an associated rheumatoid arthritis, a secondary, so definitely you need rheumatoid factor, anti-CCP to rule out it. And suppose if you are thinking of any other autoimmune diseases, so definitely ANA, double stranded DNA, so etc. for your lupus or scleroderma 70 for your scleroderma or systemic sclerosis, or RNP, URNP, that for your mixed connective tissue disorders. So Rho, low. So these are for your Sjogren's. So these are very important autoantibodies required to diagnose other autoimmune diseases along with your osteoarthritis as a part of a secondary osteoarthritis. If you think of the Wilson's disease, so definitely there will be the reduced serum ceruloplasmin levels and increased urinary excretion of the copper. Hemochromatosis, there will be the rise in serum iron and rise in serum ferritin levels. Acromegaly, there will be the rise of growth hormone with a lack of suppression with a glucose tolerance test. In hyperparathyroidism, rise in serum calcium, low phosphate levels, rise in parathyroid hormone levels. They are seen in the hyperparathyroidism. In hypothyroidism, so there will be elevated TSH and lower T3 and the T4 levels. In the gout, so the more and more uric acid levels. In neuropathic disorders, Stapes dorsalis, very, very rare nowadays. Here you need a positive EDRL test and a positive TPHE, etc. And diabetes is a very common. You know what are all the investigations required to treat the diabetes and to control the blood sugars very effectively. So these are some of the laboratory tests you require it to analyze your cause for your secondary osteoarthritis. So the management is very, very important. So in the physician's point of view, we can do a lot of things to give a good relief to our people suffering with osteoarthritis. Of course, when the osteoarthritis is very, very severe, and definitely that is an indication for your joint replacement surgeries. Okay. So the mostly the education is very important. So not only the patient, the relatives and the family members, and care should understand the condition and know what they themselves can do to help the arrest of this osteoarthritis. So if they are overweight or obese, so reduction of the overweight, reduction of the body weight, so they are very, very important. Okay. Relieve the symptoms. So symptomatic relief is always must be there. About the pain and stiffness and other symptoms of the condition should be controlled as well as the possible with the minimum risk of to the patient. See, because for the relieve the symptoms also we actually use NSAIDs or the painkillers. So the chronic usage of these things will definitely lead to a lot of the side effects like your gastritis or your analgesic nephropathy, etc. So use the drugs as when required only, not on a daily basis. Minimize the handicap. So any consequences on the function and any disability or the handicap should be minimized through the appropriate rehabilitative techniques. Limit the progression. So any factors known to be likely to worsen the condition should be avoided, and any practices likely to reduce the risk of the progression is instituted, like avoid the squatting, so walking against the steps. So these are all very important things with a minimum risk if they do not conflict with other objectives. Problems in realization of the management objectives are there. Widespread ignorance and misconceptions about the nature of the osteoarthritis. So that is a very, very common in our society. So a lot of the misconceptions, and still a lot of the people are ignorant about the disease process. Lack of understanding of the cause of the symptoms. Lack of understanding of the disability and handicap in the osteoarthritis. Inability to understand and control the disease progression. So the principles here is not only the education, physiotherapy. So the exercise program, the pain relief modalities, aids and appliances, medical treatment and the surgical treatment. There is a non-systemic nature of the disease, prevent the overloading of the joint. The most common risk here is the obesity and overweight. Appropriate use of the treatment modalities, the importance of the exercise program, quadriceps exercises, some braces, appliances, aids, and the treatments of your medical and the surgical. So the physiotherapy and the hydrotherapy, loss of the joint motion without the severe joint destruction, muscle weakness or wasting and instability of the joints, malalignment of the joints under abnormal joint use, severe symptoms not relieved by other measures can be tackled with your physiotherapy and hydrotherapy. So exercise is not for the wear the joint out, important for the cartilage nutrition. Some evidence that lack of the exercise leads to the progression of the osteoarthritis also. So don't think that osteoarthritis people should not go for the exercise. So exercise will definitely help them to improve the nutrition to your synovium. So encourage the full range, low impact movements like swimming and cycling. Avoid the prolonged loading, activities that cause pain, contact sports, high impact sports like running. So these are the things to be avoided in osteoarthritis. Otherwise, simple walking or swimming or cycling, so you can permit them. So this is the quadriceps exercises for the knee OBA. They are a proven value for the pain relief and improving the function. And everyone with knee osteoarthritis should be taught the correct techniques and encouraged to make these exercises a lifetime habit. So there is a weight on the ankle in this left side. So these are the quadriceps exercises. They are very, very useful in osteoarthritis of the knee joints. This is the TENS, that's the transcutaneous nerve stimulation. So the TENS as an adjunct to the other therapy for pain relief at the knee joint. The use of the acupuncture, TENS, and other local techniques to aid the pain relief in difficult cases of the OA is often worthwhile. These are the aids and appliances, the braces, the splints, special shoes, insoles, mobility aids, dressing, reaching, tap openers, kitchen aids, and tapping of the patella in the patellofemoral osteoarthritis. So these are all available for some of the osteoarthritis of the knee joints or the hip joints or the shoulder, etc. So these braces and splints, shoes and insoles, they are very, very useful for in some osteoarthritis patients. Use of a cane, a stick, or another walking aid. So it's very, very useful for your osteoarthritis, the hip joints or the lumbar spine osteoarthritis. So this patient who has a hip osteoarthritis has found that she can reduce the pain in her damaged left hip by leaning on the stick on the right hand as she walks. The reduction in loading can be used, and the effect on the symptoms and confidence with walking is very much beneficial by using these aids, walking aids. So these are the shoes and insoles to reduce the impact loading on the lower limb joints. So modern sports shoes, trainers, often have the appropriate insoles. Special heel or shoe insoles of the sorbitane or the viscolate materials can be used. They may help relieve the pain as well as reducing the peak impact load on the joints during walking. So the medical treatment, we have the simple analgesics, the paracetamol or a low dose ibuprofen, NSAIDs, different NSAIDs you know of, indomethacin or diclofenac or ketorolac, etc. Coxib, your celecoxib, intraarticular corticosteroids, they are very much useful in some cases. The topical treatments like NSAID creams, you have the plenty of the NSAID creams right now with the diclofenac preparations, capsaicin, chondroprotective agents like your chondroitin, diacerin, MSM. So they are all the chondroprotective and nutrascales. This is the carpometacarpal joint of the left thumb, osteoarthritis, undergoing arthrocentesis for the injection of a depot corticosteroid preparation. So steroid injection in that particular joint. So there are all the recommendations for the osteoarthritis. Weight reduction is very, very important if the person is overweight or the obese. And exercise are very important. Some aerobic exercises, strengthening or water-based like swimming. Physical measures, local heat or ice packs, TENS or ultrasound. So there are all the different things suggested by the physiotherapy population. Walking aids, already told you. Yoga will help in some individuals. Acupuncture in some individuals. And coming to the pharmaceutical agents, for pain relief, we often use the paracetamol, maybe 500 mg, 650, even the 1000 mg is also available. So give one OD or one BD in severe osteoarthritis individuals. NSAIDs of the different groups, topical agents, tramadol, so that is also very useful in some population. Duloxetine as an antidepressants, tricyclic antidepressants, so they are also useful in some individuals, but they have few side effects, especially the constipation. Intraarticular agents like steroids, hyaluronic acid, platelet-rich plasma, PRP. Nowadays, this is gaining more popularity, the PRP injections in the knee joints. So they take about 5 to 10 ml of the blood, the same patient, they centrifuge and they give this platelet-rich plasma into the joint. So by introducing this platelet-rich plasma into the joints, so these platelets will reduce the inflammation in the joints, and they reduce the hypertrophy of the synovial membrane, and they give much relief to the patient by reducing the pain, by reducing the inflammation, and also by improving the structure, a local structure in the by injecting that particular PRP in that particular agent. So it is useful in the stage 1 and the stage 2, or in some cases the stage 3 osteoarthritis, but not for the stage 4 osteoarthritis, where the joint replacement is the surgery is the answer there. As I told you that nutraceuticals like a glucosamine, chondroitin, so these are very, very popular drugs. MSM, that is a methyl sulfonyl methane, flavonoids. So these are the important nutraceuticals we often use. Glucosamine, chondroitin, MSM, diacerin, that is the interleukin 1 inhibitor, 50 milligrams diacerin. So these are all very useful drugs, but they are very costly, and they should be given for a longer period, not like an antibiotics of 1 week or the 10 days. So they should be given for a longer period to have a good effects. So finally the drugs in our hands are very few drugs, maybe the paracetamol or NSAIDs as and when required. On the long-term basis, we can use the tramadol in severe cases, and steroids in the local injections, or hyaluronic acid, or the platelet-rich plasma. But on the chronic usage, you can go for the glucosamine, chondroitin, or MSM, or the diacerin. So these are the drugs which are helpful in the management of the osteoarthritis as far as the physician's practice is concerned. But finally, if the joint is very much deranged, and if the stage 4, and definitely have to go for the total joint replacement, maybe the hip replacement or the knee replacement surgeries. So these are the different nutraceuticals like chondroitin. The dosage is about 1200 milligrams, used in the hand osteoarthritis. Glucosamine, 1500 mg, positive effect on the symptomatic and the structural outcome of the knee osteoarthritis. Diacerin, 50 milligrams, useful in the hand osteoarthritis. MSM, 2000 milligrams, as an adjuvant to the glucosamine and the chondroitin. Flavonoids, effective as in many clinical trials. Omega-3 fatty acids, a clinical benefit in high doses only. So these are the important drugs available in our hand right now: the chondroitin, glucosamine, diacerin, MSM, and omega-3 fatty acids. So they can be useful in osteoarthritis stage 1 and 2 and 3 in those people who can afford to use them for a long-term basis. What are the surgical procedures used in the management of the osteoarthritis? So there is an arthroscopic washout, or the tidal irrigation, joint debridement, bony decompression, osteotomy, and finally arthroplasty. So out of these all procedures, I think nowadays arthroplasty, so the knee joint replacement or hip joint replacement, they are the very, very common in our society. So the indications for the joint replacement surgery: pain affecting the work, sleep disturbances, difficulty in walking, difficulty in leisure activities. So these are all the indications for the joint replacement. And finally, your radiological definitely will tell you very, very severe osteoarthritis. Complications nowadays are very, very low. So because of no sepsis, very, very low. Loosening and lifespan of the materials like mechanical failure. Nowadays they are using the very good material for these replacement surgeries. So I think the lifespan of the materials also increased a lot nowadays. And the loosening and the sepsis are very, very rare in the hands of a good surgeons. But still, in some people with the diabetes, uncontrolled diabetes, or other metabolic disorders, there may be a chances of getting the sepsis. So before subjecting these people, so definitely the blood sugars and other things has to be controlled very effectively, and then they post it for joint replacement surgery, because this is not an emergency surgery most of the times. So you control the metabolic diseases very effectively, and then only hand over to the replacement surgeon. So finally, this is the pyramidal approach to that management of the osteoarthritis. So first one, education, counseling, dietary advice if overweight, reassurance, teach the appropriate exercises to maintain the joint mobility and the muscle strength. That is for the everyone. So the for everyone, that is the joint, education and counseling and exercises are very, very important. In some people, teach the joint protection techniques, review the function of the handicap of some physiotherapy, assess the biomechanics, need for the shoe alterations, your aids, walking aids, etc., shoes or insoles, some simple analysis as and when required, and short course of the NASIADs for the symptomatic relief. But very few people, maybe the physical techniques for the symptom relief, the physiotherapy, or maybe the intra-articular steroids, or intra-articular hyaluronic acid, or your plasma-rich protein, platelets-rich protein injections, and then finally the surgical procedures like joint replacements. So this is the healthy hip and the arthritic hip. So you can see the hip joint here, the ball and socket joint. So in the second picture on the right side, you have the eroded cartilage here and the swollen joint capsule, and the bone is distracted and excess joint fluid. So these are all the changes in the arthritis of the hip joint. See the hand joint osteoarthritis, the fusiform swellings of the joints here. On the distal interphalangeal joints, you will have the Haberden's nodes. So this is the OA of the knee joints. So limitation of the movements. See the OA of the left hip. See the joint there. So joint capsule destruction, narrowing of the joint space, bony destruction, cartilage destruction, new bone formation, osteophytes. So these are all seen here. See the instability of the joints and ulnar deviation. So there is an inflammation there. See the joint there. So the narrowing, etc. You can appreciate in this. See how is the normal and how is the abnormal one. So torn out joints. So this is the hand OA with the Haberden's nodes. See here the Bouchard's nodes in the proximal interphalangeal joints. See the bilateral genu valgum secondary to the osteoarthritis, the both knee joints. This is very, very common in our rural Indian population. Okay? So very common. Nothing can be done here. See the hand OA, a degenerative changes the distal and the proximal interphalangeal joints and the first carpo-metacarpal joint on the both the sides. You can appreciate the first carpo-metacarpal joints here, the destruction, the narrowing, etc. See the joint here, narrowing of the joint space, new bone formation, osteophytes, etc. So the knee, AP and lateral view, the medial compartment of OA, there is the joint space narrowing, subchondral cysts, and osteophytes formation. The first carpo-metacarpal osteoarthritis. Okay. Yeah. So OA left hip, joint space narrowing, large subchondral cysts, severe deformity of the femoral head. So the only answer here is the replacement surgery. Thank you very much for your patient hearing.